Martha, for the wonderful opportunity. I think it's a very good session because OOPS is something which everybody has to look for when you are, because it can catch you completely, totally unaware of the whole thing. You can see, I'm going to talk to you about the OOPS in IOL implantation. And you can see here, this patient has got a Crystal lens in 2009, came all the way from Coimbatore. At that time, I was the highest number of Crystal lens implantation I did. You can see the Crystal lens broke. You can see this, only the Crystal went inside, the lens was outside. You can see that completely broke. And this, you have to be very, very careful. The lens fractures are not uncommon, especially with the silicone lenses, the Crystal lenses, silicone lens for the matter. You can see this patient, you can see the lens has gone through the, because the shooters, you have to be very careful with the shooters. I'll show this video again. You can see this shooters. When you do the shooters, what will happen is when you do the push tape technique, there's a possibility of the lens rupturing the PC and going into the vitreous cavity, and that's what has happened. You can see the lens dancing in the vitreous cavity as well. And these are preloaded lenses. You have to be very, very careful with these preloaded lenses. You can see this is a preloaded lenses. I will not mention the name of the company, and you can see there is a big hole right in the center of the thing, and whenever there is a very tight resistance of the injector, and this is, I think, one of the reasons why you should not inject at all. And this I have learned over a period of time. You can see, and when one of my postgraduates is asking, what is this hole in the center? I said it's a pinhole through which the patient can see better. Okay, and this is what you call I call it the donut IOL. And this is another patient, again a preloaded lenses, and made by the Zeiss company. You can see that it was an apparent surface optic, but only the optic was there, and the haptic came later. And you can see this both the optics were completely fractured, and only the optic was inside. And these are all things we have to be very careful. And I try to, obviously, we have to explant these lenses and put these lenses again. Again, this is the trifocal lenses, and you can see here, which is got a very tight injector. When you have resistance, as I told you, please don't inject, come out of this thing, probably reload the lenses. You can see this is the 3 zones of the trifocal lenses, the zone 1, zone 2, zone 3, and all the 3 zones you can see beautifully, and the cracks you can see on the lenses. Obviously, these lenses we have to explant, and we have to cut these lenses and explant. These are this I call it the lockdown effect. You can see here, this lens was kept in the cold storage for a long time, and probably the viscoelastic also was used as a very cold storage, very cold, and you can see the lens is completely white because of the dense deposits of the viscoelastic on the lens as well as on the surface of this thing. Again, you can see this aniridial lens. Okay, this aniridial lens actually it went for suturing, but if you want to do it a glued, this I'm trying to do a glued IOL in this aniridial lens. You can see here I'm trying to pull it. The haptics are a little fragile in aniridial lenses, and this is what we have to be aware of that, and probably take precautions and handle these haptics, because aniridial lens is very difficult to get. Fortunately, we had another aniridial lens backup in this particular patient, and we were able to do it. Again, the lens, the kissing haptics is not uncommon, and especially with Acrisoft and the Technis lenses. And the kissing haptics sometimes takes a longer time. This probably took about 5 minutes for me, and I was completely using. Sometimes you will have to use a 2 second instruments to open it up, and use some viscoelastic as well, and probably do a lot of irrigation. I can see there's a PHACO tip which has been used for a long time. The PHACO tip detached and was lying in the anterior chamber, and you can see this the tip detachment, and this is also a very, very rare scenario. This is another, again, a patient with the preloaded lenses. You can see the optic is actually on the posterior, stuck to the posterior surface of the optic, the haptic. And this is one of the main problems, and very difficult to solve also, because it's very difficult to go underneath the optic and try to release the haptic. And this is what will happen, and sometimes it takes a long time, and you have to do a lot of maneuvers and acrobatics in the anterior chamber to bring it up. And fortunately for me, the haptic got released, and the patient did very well. Again, you can see the second instrument which got detached, and you can see it's lying there. And this is again something which you have to, we have to be very, very careful. Again, the wound assisted technique of implantation of lenses, you have to be very careful, because if you don't inflate the chamber, then the anterior chamber, it can buckle. And if you don't push it enough, what will happen is the lens will get stuck like this. The lens gets stuck like this. This lens got stuck like this. This is an MI60 lens, and it was a hyperopic lens, about 30 diopter, very thick lens as well. So what it is, it was not going inside, it was not coming out. So I put another incision, put a lens inside the eye, and remove this lens. Actually, if you have a stuck lens like this, always go posterior to the incision and try to open up the incision a little more and try to pull the lens out. And always examine the lens, because sometimes the lens can be damaged during the implantation. Probably replace the lens as well. Again, bimanual IA, you can see the bimanual IA completely detached and lying in the anterior chamber. You can see that the detachment of the bimanual IA, which is again seen. The sleeveless, the PHACO, you can see the sleeve got cut here and got attached here, and then got detached again outside the eye. And these are some of the oops. Again, I told you I already shown you this, wherein the optic comes first, the haptic comes later in this particular preloaded lenses. The preloaded lenses, we have to be very careful now. All the companies are coming out of the preloaded lenses. The diamond knife, you can see the diamond knife going inside, and then when it came out, it got detached completely from the hub of this thing. And you can see this is a diamond knife, and next day it was in the Sujata's ear, it became the diamond wife. And you can see here the MST forceps, which is used again for the glued IOL. And this particular this thing, when aniridia lenses with the PK, I did, and you can see this the MST forceps also got detached and lying down. Fortunately for me, it was lying down in the angle, and I was able to take it off without any problem. Sometimes you can go inside and produce an intraocular foreign body. This is a haptic. You can see this is a haptic, which is got stuck. This is an Invista lenses. You can see here. We tried to pull the haptic, because these are all the medicinal injectors. These medicinal injectors are very, very difficult. They are what we call as the green injectors. And sometimes when you try to pull the haptic, it gets completely fractured, and you have to probably remove the lens and extend the incision, pushing the lens. That's what happened with this particular case. But you can see here the chopper, the long chopper. You can see here very carefully what is happening is, and the chopper got detached, and not only detached, it also got emulsified by the PHACO emulsification. And this again, oops, this thing. Again, these Invista lenses, as you know, the Invista lenses take a very long time to unfold inside the eye. And this particular Invista lenses, you can see here, it is lying down in the anterior chamber. A lot of acrobatics was done. 3 minutes has gone by, 5 minutes has gone by, 8 minutes has gone by. I tried to unfold the lens, but the lens was not unfolding. And obviously, I had to explant this lens and replace this with another lens for the matter. Again, the plunger, again, is another patient with the preloaded lenses. Again, you can see here the plunger, the silicone plunger sometimes can get detached along with the lenses as well. And it's very difficult to remove the silicone plunger, because these silicone lenses, these plungers are very, 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 very slippery as well. And you can see here, I'm trying to remove it because it's not holding with the forceps, but I had great difficulty in removing it. And this also we have to keep in mind. This is another patient wherein it's a preloaded lenses. One lens came, and then, oops, we saw just wait for some time, you'll know what is happening here. You can see there's another lens also coming out into the same eye. And this patient, I wanted actually bilateral simultaneous cataract surgery, but both the lenses were in the same eye. And you can see here, this is haptic, as I told you, the haptic attachment. And there's the green injectors. You have to be very, very careful. Sometimes the haptic can get caught in the injector. So what I do normally is to do what is called the ocular episotomy. And you can see here, I'm putting a 11 blade. When you create a space between the cartridge and the silicone, the silicone tire there, and the cartridge and the silicone tire, then you'll be able to release that haptic without any problem. Without fracturing or deforming the lenses as well, deforming the optic. And this is what happened. This is an in-focus lens. I was able to put the in-focus lens without any problem at all. And finally, last but not the least, all of a sudden you can see that the silicon handle from the microscope falling on the eye after a lucentist injection, and this can also happen as a oops. Thank you very much, Namrata, for the wonderful this thing. These are all things which we are recorded. So the take-home message is that please record each and every case, because you do not know when your oops is coming. Thank you very much.
Thank you so much, Dr. Mohan Rajan. That's a treasure of